Hi, my name is Jillian Wade. I'm presenting the patient perspective of recognizing privilege while accessing the healthcare system. The patient story I selected actually belongs to my sister Jenna. She is a 25-year-old white female. She's college educated. She has PPO insurance and she has a high health literacy. So in her experience, she presented to the emergency room with right lower quadrant abdominal pain at about 23:30. She had an ER wait time of about 10 minutes. Technically day 2, she was diagnosed with appendicitis at approximately 1:30 in the morning. She underwent a laparoscopic appendectomy around 9 o'clock the same morning and was discharged home to self and family care at about 2100 that night. She had a follow-up appointment at an acute care surgery clinic 2 weeks later for her post-op check, and she was cleared post-op as being in good health. From her perspective, her experience went very well, or as well as can be expected. She had a short ER wait time. It was less than 10 minutes. Though she did have a mildly delayed diagnosis, it wasn't due to any hospital factors. It was due to her own body habitus factors. She required a CT of her abdomen. From her perspective, her experience went very well, or as well as can be expected. She had a short ER wait time. It was less than 10 minutes. Though she did have a mildly delayed diagnosis, it wasn't due to any hospital factors. It was due to her own body habitus factors. She required a CT of her abdomen with PO contrast after her right lower quadrant ultrasound was non-conclusive, but that was due to her being underweight and fairly skinny, so they couldn't get a definitive image. She was promptly medicated for pain control, and her pain was, from her perspective, her story has a little bit of all of the domains, really. First, patient-provider communication. She received a plethora of illness-related information. She received education on appendicitis and laparoscopic appendectomy from 3 different surgeons just due to the timing of her diagnosis and then the selection of the surgeon. So because she was originally diagnosed at about 1:30 in the morning, the general surgeon on call came and gave her the spiel about appendicitis. Then there was discussion about changing to surgeon within the group that I work in. So the surgeon who was on at the time came in and did the whole discussion. And then after 7 o'clock, since her surgery was scheduled for 9, the surgeon who was coming on at 7 o'clock then took over the case and did the same thing, came in and discussed appendicitis and the risks and benefits of surgery with my sister. So she received education from 3 separate surgeons. She also received a lot of diagnostic and health information in those 3 education sessions. And they also had a shared explanatory model of illness. Both the surgeons and my sister are very familiar with Western medicine and the framework in which it works. One thing, though, was complementary and alternative medicine, or CAM, was not addressed by any of the providers, most likely because the providers just assumed that she didn't actually use CAM, which in her case was correct. So as far as shared decision-making and respect for patient preferences goes, she was allowed to change general surgeons to a surgeon that I knew and was comfortable with, which is huge shared decision-making between both her, myself as a family member, and the surgeons that I work with who are willing to do her surgery on their day that they were not on surgery call. So experiences leading to trust. She met several factors that help build trust between patient and provider. She was race concordant with all of the surgeons who came to talk to her. They all share the same primary language, English, so no translator was needed at any time. And she had accessible and coordinated care between all of her providers. As far as linguistic competence, my sister has a very high health literacy. She is very well educated. She has a college degree. She's actually currently pursuing education in healthcare as well to become a speech therapist. So she definitely understands what's going on. As a result, she was adherent to treatment and follow-up care, and she also has the benefit of excellent baseline health status. She felt very comfortable disclosing her symptoms, discussing her concerns with the providers, and as mentioned before, they had the same primary language, and her care was accessible and coordinated between providers. So a discussion of all of these domains coming into play together. My sister is the epitome of a privileged patient. She's white, she's English speaking with English as her primary language. She's middle class, she has a private insurance, she has connections within the hospital that she went to, and she has high health literacy. On top of that, she and the providers have a shared explanatory model through the Western medical perspective. They have a common understanding of the cause of her illness and how to proceed from there. In addition to that, her care was absolutely patient-centered. We changed the surgeons, as I've mentioned multiple times, and she was also discharged home earlier than usual, with essentially a good support system of myself, her very own nurse practitioner that was going to be taking care of her in the few days post-op. And she has access to great care, a great hospital, and not only that, but the means to pay her out-of-pocket costs that are not covered by her insurance. So she meets many criteria for being the absolutely privileged patient. So while my sister was had the ideal patient-centered care, here I'm going to talk to you about some potential solutions on how we can apply this patient-centeredness to all other patients' care. So as far as patient-provider communication, it's important to ensure adequate health-related information is given to all patients so that they can make their own informed decisions. An example of this is using printouts from UpToDate, Epocrates, Medscape for patients who are able to read. I think this is severely underused. Another thing is that that could have been better about my sister's situation is it's important to assess CAM use. Also, it's important to explore the patient's explanatory model of illness and disease. For example, if this also goes into to tie in with CAM, if, for example, my sister had thought that her appendicitis was caused by a spirit or from doing bad deeds or imbalance of hot and cold, she and the providers would have had some definite clashes in how they would think to proceed in her care. As far as shared decision-making, it's important to explore the family and the patient preference for treatment options. Sometimes what the providers want is not what's always in the best interest of the patient and the patient's family. Sometimes it's just more convenient for the provider or something like that. So it's important that the decision-making in the care is shared. So, experiences leading to trust or distrust, race concordant providers if possible. Obviously, this is not possible a lot of the time. But if it is, it should be attempted. Also, if a patient request for treatment or tests is being denied by the provider, it's essential to educate the patient on why it's being denied so that they have an idea of why you're doing it and that you're not just dismissing their concerns. Experience of discrimination, it's important to build trust with your patient with open, personable, compassionate communication so that they know that you care about them personally. And as far as fostering trust, you can see the bullet points above. For linguistic competence, I think sometimes providers see a lack of fluency in English or a lack of health literacy as being the patient is not interested in their care, which is absolutely false. So it's really important to use translator services and encourage the patient to use a professional translator rather than relying on a bilingual family member, because that family member is not always the most reliable translator, and they maybe don't know some of the words, don't know some of the concepts that the healthcare providers are talking about. And here's my source that I use, the Cultural Competency and Quality of Care, Obtaining the Patient's Perspective. Thank you very much for watching my presentation.